PPV, SPV, they will have an impact, because there will be a falsely if we use a cutoff of 11% or 12% as suggested by the majority of the studies, then there will be a very high false positive result because of this. But if we need to have more data. I mean, perhaps in future, if this society grows, we'll be able to do more studies on such subjects. What should be the cutoff for? It has to be a higher cutoff. What should be the cutoff for such level of abdominal hypertension? What should be the cutoff for this level of abdominal? Maybe in future we can think about that and go this thing, or whether we can at all use it. If we go for I think end expiratory occlusion pressure is something which can be useful irrespective of the abdominal pressure. That 5% elevation of cardiac output after 15 seconds of abdomen end expiratory occlusion, that if you press the button for it, can still be useful even irrespective of our abdominal pressure, whatever may be the abdominal pressure. What about the IVC? IVC distensibility probably will be impacted strongly by the presence of abdominal pressure, because inferior vena cava itself is inside the abdomen, and the results will not be as reliable as in a patient with a normal abdominal pressure. What about PLR? Yes, there are controversial data. Some people believe that PLR can still be used, but many others believe that PLR, because again, when we do the PLR, out of the 300 ml of blood, a large amount comes actually from the abdominal compartment. So they will have an impact in the things. Again, PLR will be falsely positive, negative, whatever. PLR will not be a very reliable in things. But I think superior vena cava collapsibility, which is superior vena cava being completely in the intrathoracic compartment, and expiratory occlusion test, these are the two tests which may still be useful in abdominal when the abdominal pressure is high. But definitely no PPV, SBV, SPV, and all these things, they require more validation in different types of abdominal pressure. And Manu can help us.
And some author they suggest like the pressures are not reliable, but the volume are still reliable. You can still rely on the volume. And like, what about like using abdominal perfusion pressure instead of MAP? Because MAP may not be a appropriate target in case of fluid resuscitation in this patient.
Shall we target MAP at all for fluid resuscitation? It's coming to the fluid resuscitation. Our target of fluid resuscitation is to achieve perfusion of the tissues, tissue perfusion. And to do that, we need to see whether the patient is hypoperfused or not. We need to see whether the patient is fluid responsive or not. Fluid responsive, whether there is a good possibility of improvement in cardiac output following a fluid bolus. And thirdly, that we should be quite confident that the patient is not fluid intolerant. That means if we give fluid, the patient is not going to be more worsened by the fluid. So all these three factors need to be considered. I don't think we target the MAP as such, mean arterial pressure, for maintaining this, the mean arterial pressure for fluid resuscitation as such. This is my personal point of view.
The target, like as per cerebral sepsis guideline, the target is still MAP. No, MAP is 65, like they recommend.
See, MAP is not our ultimate aim. Our ultimate MAP is, see, once you want to achieve the tissue perfusion, we can improve the tissue perfusion either by improving the cardiac output or increasing the DO2 by cardiac output, hemoglobin, or oxygenation, or we can improve it by the upstream pressure. MAP can be the upstream pressure for delivering the blood volume to the tissues. So MAP is just one. It's one of the battles. It's not the war. This is not the ultimate aim of our war. So we actually don't target the MAP. MAP is when we go for here to Jaipur, we have to go through Daruera. So Daruera is just a MAP. This is what my take on.
Thank you for explaining. Manu wants to say anything, or
Manu. Manu has to do a good job in making this. How do you use PPV, SVV, and what should be the cutoff in appropriate
Yeah,
hepatitis?
I think they can still be used, but
Yes.
the problem is that the threshold values will change. So normally we have the feeling if SVV, PPV goes above 12, 14%, then you're entering the fluid responsiveness zone. But if abdominal pressure goes from 10 to 20 millimeters of mercury, the SVV PPV threshold may double as well. So it will rather be 20, 25%, beyond which your fluid responder, and below it's just a delta up phenomenon. If you would separate the inspiratory and expiratory part in your pulse pressure variation, and that you can do very easily at the bedside. So you have a pause, so disconnect the ventilator and you look at the pressure wave curve. So I would say you can use them. You expect them to be higher, but to turn it around, if SVV, PPV is 4% and abdominal pressure is 20, then for sure you know that the patient is not fluid responsive. So you can use it also to avoid giving too much fluids. When it comes to the passive leg raise, there you must be aware that it can be false negative because of impedance of venous return. And for ultrasound, like inferior vena cava, I'm not a fan. I would not use it because it has many limitations and pitfalls. When it comes to targeting, I'm in favor of abdominal perfusion pressure, although there is no data, and there is just one retrospective study. But I think it makes more sense. We are now collecting some prospective data in relation to AKI, renal perfusion pressure, and venous congestion of the kidney. So I'm convinced that in the future, now that we have techniques to measure abdominal pressure continuously, we will have more information to guide resuscitation towards abdominal perfusion pressure or maybe renal perfusion pressure rather than MAP. And when it comes to MAP, you always have to relate it to the previous history of the patient. If he's known with arterial hypertension, a MAP of 65 probably is not enough. And this is what all the studies have shown. On the other hand, in the perioperative phase, hypotension is related to morbidity and mortality. So that, of course, we need to avoid.
Superior vena cava can be still useful. Manu, what is your take? Superior vena cava, if we have the proficiency of performing transesophageal echocardiography, then SVC can still be useful because it's being a completely intrathoracic organ. And so we can still use SVC collapsibility as a parameter, though the proficiency of TEE is required for that.
Yes and no, because intra-abdominal pressure will be transmitted to the thoracic compartment. It will result in an increase in intrathoracic pressure, esophageal pressure, and hence may affect your SVC as well.
But that will be both in inspiration and expiration.
That's true.
So the percentage of change will still be useful because SVC being completely in the thoracic cavity, so change will be there both in inspiration and expiration. So changes, the percentage of change during different phases of respiration will still be useful. Instead of, I mean, IVC is almost useless when it comes to, at least for the abdominal, but SVC can still be useful because being a thoracic organ, completely a thoracic organ, and the changes will be, the impact will be there both in inspiration and expiration.
Yes, but you may imagine a higher impact at expiration when you have an increased intrathoracic pressure, which may compress the SVC where it normally would not do so when abdominal pressure would be normal. So I'm not sure. I'm not sure it's completely trustworthy.
And as far as Dr. Supradip, I know that MAP is not the criteria, but then for our junior colleagues who are new to ICU, at least it gives them some rough idea what they have to target. Defining tissue perfusion and assessment will take some years of experience to assess that. But at least for the newcomers who has to start, you can just tell them to target a MAP of 65. I know it is not an absolute criteria to be targeted, but yes, for starting, we can tell them to do that.
No, I think I don't agree, but we can discuss it about Parveen in some other time.
Yeah.
Well, I think capillary fill time is a very simple thing to be measured.
Yeah, that is also
And we can discuss it out. I think it's not out of contest, but we can discuss it out.
Yeah.
Now, my next question is for Dr. Manu Malbrain. Since he is the one who coined the term polycompartment syndrome, I would like to ask him what exactly does it mean?
Okay, thanks for the question. I'm not the inventor, but I think before there was the multi-compartment syndrome, it was called, which was observed in patients that suffered from abdominal and intracranial trauma. So those patients had intracranial pressure monitoring and abdominal pressure monitoring. And it was seen that in some of these patients, when you performed the decompressive laparotomy, the ICP would normalize again. So this gave rise to the idea that the organs are connected and you have this kind of crosstalk interactions. Because the multi-compartment syndrome is something we know from peripheral limbs, like you have multiple muscle compartments that can be affected in the legs. We proposed polycompartment syndrome to avoid confusion. So the definition is that it is more than one compartment that is affected and pressure above normal, which for all compartments is around 10 to 12 millimeters of mercury. And once you have a polycompartment syndrome, you will have these interactions and the crosstalk between the abdomen and the lungs and the brain, and so forth. And I think it's very important for every clinician to understand when you're measuring a compartmental pressure, when it's ICP, that you know that it can be increased because of a problem in the lungs, like a pneumothorax or a high PEEP or an auto PEEP, or a problem downfall in the abdomen with abdominal hypertension, so that you don't treat the number. ICP is 20, I have to do decompressive craniectomy. No, that you check other potential causes for increases in this compartmental pressure.
Okay, thank you, Manu. Now coming to the monitoring part, as we can only recognize increase intra-abdominal pressure if we monitor it, if we measure it. As they say, measuring is knowing. So my question is, Dr. Parveen, like what are the conditions where it is imperative to measure intra-abdominal pressure? Then what are the technique we use? And what are the pitfalls and the barriers? Because we are not often use it in India often. So what are the barriers that are we're not measuring it so often? Unmute yourself.
I'm doing it. So when we are talking about conditions where it is imperative to measure IAP, I think I have mentioned all the risk factors earlier. So any patient who has 2 or more risk factors for developing this intra-abdominal hypertension, we should try to measure IAP. And of course, as you rightly said, no, if we know something, then only we'll do something about it. Many a times people are not even aware of these things, and that is why it is less measured and less known thing. And if there are 2 or more risk factors, it becomes imperative to measure IAP. Then there are direct methods or indirect methods. Direct methods are very invasive, less commonly used, and most commonly used is, of course, intravesicular measurement of, which is a surrogate marker for intra-abdominal hypertension. I think technique, everybody knows that we can use that Foley's catheter. We have some centers are using that Foley's, which have a separate sample collection port that can be used for attaching that transducer. And the method is, of course, creating the fluid column and attaching it to transducer, and then we can measure IAP. And the next question was what did I miss?
What are the pitfalls of measuring? And
so pitfalls are, first of all, technique has to be correct. We should know how is being measured, because suppose if somebody is measuring it in a different way, erroneous interpretation, that is very, very important to recognize. Because if we over measure it, sometimes it may lead to overcorrection of the things, which is not imperative, which should not be done. Then serial interpretation, serial measurement is very, very important. It has to be sustained, as I mentioned in the beginning in the definition, that it has to be a sustained and repeated elevation. Single measurement does not carry any value. So it has to be serial monitoring. Then sometimes erroneous recognition of IAP, thinking that it is the root cause of all the problems, that should be avoided. First of all, we should try to correct all the possible causes other than this, which can be corrected. Then we should be ruling out by taking proper history and focused clinical examination to rule out other causes. And then it should be dedicated to that it is because of intra-abdominal pressure. And then all the team members, as I have rightly said, that team members, they should know what method they are using, and we should cross check it. And as far as the measuring part is concerned, it has to be measured in millimeters of mercury, the basics. It has to be measured in supine position. It has to be zeroed at the level of iliac crest in the mid-axillary line. And it should be measured at the end of expiration. And maximum 25 ml of saline should be instilled, and it should be measured 30 to 60 seconds after the instillation of saline for the relaxation of the muscles. So these are the basic things for measurement of IAP.
my follow-up question is that, like, we have been knowing the effect of IAP for a long time, but still we don't measure IAP regularly, at least in India. So what may be the barriers of measuring IAP monitor? Do you can think anything about this?
Sorry?
Like, what are the barriers of IAP measurement? Like, why are not measuring it too often?
I think the focus remains on other conditions. We over the time, the concept is changing. Now people are aware. Most of the time, surgeons are also aware about this condition, that it can cause ACS, and then they have started leaving the abdomen open, because people are still not aware of this condition, and that is why it is being less commonly used. This is what I think.
Okay, any comment from any others? Robin, can you turn a video on, please?
Sorry?
Your video is off.
Sorry.
Any comment from any other panelist?
One reason I feel we used to measure a lot of abdominal pressure. Previously, we used to have this kit available. You remember? And for last good 8 years, this kit is no longer there in our country. So without this kit, it becomes very difficult using that IV fluid thing and measuring it manually, how accurate it is. I don't know, this it becomes very cumbersome measuring it in such way, whereas it used to be a very easy way to measure. Can it have an impact? I don't know. This may be a reason why.
And some centers are not using that Foley's catheter, which have a separate port. Most of the centers are using the normal Foley's catheter. So puncturing the catheter, putting that thing, I don't know how good it is from this infection point of view, because
correct. That's right. This may be one of the reasons why it is hindering. Apart from, of course, we are still not aware about the condition. Lack of this. Manu has. Can we measure this with our the gastric pressure? Gastric pressure. Everybody has got a rice tube in place. Can we, instead of Foley's catheter, this is the standard one. How reliable is the gastric pressure?
Yep. So gastric pressure and intra-abdominal pressure, bladder pressure are very well related if the abdomen behaves like one fluid compartment. You can imagine conditions where this is not the case, like if you would have a problem with the liver, a trauma, or a packing, so that there is an issue in the upper abdominal compartment, or when you would have a pelvic trauma with hematomas compressing the bladder. So in that condition, bladder pressure will be higher than gastric pressure. But in normal situation, gastric pressure can be used interchangeably with bladder pressure measurements. But the problem with the stomach is that you also need to have a water column, so you need to have some fluid in the stomach. We've done many years ago a study using nutrition has the transmitting medium, and it works where you have the height of the nutrition column, like you would look at the height of the urine column, but then the density of the enteral nutrition may have an impact. But you could do it by just flushing some water into the nasogastric tube, connecting it to a pressure transducer, the same way as you do bladder pressure measurements. There is one company still on the market, which is Spiegelberg, and they have a nasogastric probe with an extra balloon on the tip that allows you continuous gastric pressure measurements. But it's kind of a very tiny catheter, so you cannot use it to provide nutrition and to vent the stomach and to measure at the same time. So you need to put it in addition to a normal nasogastric probe, but you can. And now there is an American company too. You have Potrero Medical and Sentinel Medical. They produced a Foley catheter with an extra balloon that measures bladder pressure continuously. And we just done some in vitro and animal studies, and it correlates nicely with the gold standard. So maybe in the future we will have these technologies available because I'm convinced, but I'm biased, that abdominal pressure is the sixth vital sign. And as we have blood pressure, temperature, saturation, respiratory rate, pulse, and so forth, I think we should have intra-abdominal pressure as a vital sign, and if possible, continuously, to target resuscitation endpoints, to interpret filling pressures, to set the ventilator, because you need it for recruitment, for best PEEP, to interpret ICP. So it's really connects to everything we do at the bedside, and it's easy to obtain, and it gives you so much extra information besides prevention of abdominal hypertension, because to prevent it you have to measure it, and prevention of compartment syndrome.
I know how passionate you are on abdominal compartment syndrome. First time I met Manu in 2012 or 13, somewhere in Brussels. He was promoting his book on abdominal compartment syndrome there. But I just want to know that gastric, if we use the gastric thing for the pressure, what should be our zeroing? At what level shall we zero? For the bladder, we do that for the iliac crest.
Yeah. So if the patient is supine, you have your mid-axillary line. So if the patient is supine, you use that level. Okay. For the bladder, we say where it crosses the iliac crest, and that's for a reference. If you would change the position of the patient, but the mid-axillary line is your zero reference. I agree that it's not ideal, because if your abdomen is like this, by definition, the zero should be in the very middle of this fluid compartment. Like we have in the brain, it should be in the middle of the brain. So depending on anthropometry, zero should be adapted, but we don't have any evidence to support that, but it makes sense. If you have a patient with a belly like this, and your zero is here, of course, then you will have the water column pushing on your zero, and you will have a false increase if your zero is too low.
Correct.
Thank you very much for your explanation. Next question for Dr. Pradip is that once IH and ACS set in, how can we monitor progression and recovery, and if there is a role of biomarkers for the same?
Thank you, Astha. So with regards to the endpoints of improvement or progression towards favorable trends is definitely clinical endpoints. So obviously the organ functions are improving, urine output is getting better, lactate is coming down, your airway pressures are coming down, and your gas exchange PF ratios are improving. I think these are the definitive endpoints to suggest that your intra-abdominal hypertension, of course, with monitoring of intra-abdominal pressure. So these remain the basic tenets to see how our intra-abdominal hypertension or compartment syndrome is progressing towards getting better or towards worse. So clinical endpoint still remains the quintessence. So if you look into the literature, there is a lot of enthusiasm to look into any biomarker. So lactate may be still a good, because as extensively discussed, if perfusion is compromised, then lactate obviously starts worsening. Then you have worsening hemodynamics, then you have worsening urine output, worsening PF ratio. You know, abdominal compartment is not settling and things are getting worse. But if these parameters getting better, you know, the abdominal compartment is getting better and your intra-abdominal hypertension is coming down. And this may concomitantly be related to your intra-abdominal pressure monitoring. So there are biomarkers which have been studied, and you have to really look into the literature. So, but this is all in the experimental. I think there's one study by Ashish Khanna who has did a correlation with intra-abdominal pressure and CA125 as a marker. So I would think it is just a observational correlation that is there, and possibly we wouldn't be contemplating on doing such biomarkers. And D-lactate is another biomarker that has been studied, and these are all extremely small studies. And there is another one called FABP, which is intestinal fat binding protein, fatty acid binding protein. So this was done in a study in 10 patients. As I said, these biomarkers remain experimental. So the only recent study and little bigger one is the CA125 correlation with increase in the IABP, increase in the abdominal pressure. But I think they remain experimental at this stage. So possibly we wouldn't be contemplating at this point of time on any of these newer biomarkers. Maybe lactate is something that we could keep an eye as a standard sort of a tool to see if your perfusions are improving and your abdominal pressures are getting better. So that would be my thoughts there.
Thank you, Dr. Pardip. Now coming to the management part, like what are the precautions we should take to prevent development of ACS? And like once it happened, like how will you manage it without doing any invasive procedures? To Dr. Supradip.
Okay. Okay. If you for the prevention part, I think the most important aspect to realize and understand that is existing. And Dr. Parveen has beautifully pointed out that our awareness, increased awareness that it exists and it needs to be monitored and it needs to be taken care of. I think this is the most important thing. I think I must thank the whole people who have actually spread the information, including Manu and Kaur, and there are so many others. So this is the first thing. Another things we have realized, as Manu has pointed out recently in the earlier in the talk, that fluid, our knowledge and about the fluid management and appropriate fluid management has improved over a period of time. So we are seeing less number of patients with coming up with this thing. This has also been pointed out, Dr. Suchitra Ranjit, the great pediatrician from Chennai, who has shown that patients who were earlier resuscitated, dengue patients, pediatric patients with dengue, who were resuscitated aggressively with a lot of fluids, they ended up in abdominal compartment syndrome. So, but as we have, again, we have improved our understanding of fluid management, So we are reducing the things. Improvement in things. The awareness and appropriate management of fluids, these are the two things which can improve the prevention aspect. Regarding treatment is, of course, once it sets in, we need to understand three things. What is the level of pressure? How much is the organ dysfunction and how serious it is? And finally, what is the cause? What is the cause of this abdominal raise in the abdominal pressure? Whether the cause is intraluminal, extraluminal, or it is the abdominal wall itself. If it is the intraluminal, then decompress, or whatever way, maybe by reduce the, use the gastric aspiration, or maybe for Ogilvy syndrome, you can also go for colonoscopic decompression. If it is an extraluminal, as Pradip has pointed out very clearly, that we can use drainage of the fluids minimal invasively, or we can remove the gases. If it is a wall problem, then we need to take care of the wall, like give sedation, relaxants, maybe if there is eschar-otomy, remove the dressings. And if everything is possible, then of course, as Manu has shown initially, that a lot of people with laparostomy, open abdomen. So these are the things. I think one thing I have noticed in my hospital too, that even in last 17 years, I've been practicing in the same hospital. Over a period of time, our surgeons, they are now more keen that yes, there is a condition like abdominal compartment syndrome which can exist. So when they do take care of their stroma patients, they think of, okay, this can be a possibility. And another thing is when they release a large abdominal wall hernia or then also they are very much now they are very much aware that this can happen. If you push the whole content inside the abdomen, the pressure can go up. So this is my take. I think there are
Manu wants to come in.
Yes, no, I see that time is running fast, and I have a hard stop within 3 minutes. So I fully agree with what Supradip suggested. I think medical management comes first, prevention, the fluids, and we see it less often because it mainly was iatrogenic. But I think, Saurabh, my last question is about the microbiome. Can I
please
answer it now? And then I have to apologize because I have to leave and drive 2 hours to the hospital. So when it comes to gut microbiome in relation to intra-abdominal hypertension, because abdominal hypertension may have an impact on mesenteric flow, it may also have an impact on the microbiome. There is some preliminary data showing that microbiome may change to a more aggressive one, and we may have abdominal sepsis and bacterial translocation in this setting. So definitely yes, and I think it will be an area for future research.
Thank you. So we have the final question. Astha can.
Yeah, Dr. Pradip, I'd like to know from you, what are the invasive methods of management of ACS in case conservative techniques fail, and what are the implications of having an open abdomen?
Yeah, thank you, Astha. See, increasingly right now, as I'm speaking, we have a severe pancreatitis whose abdominal pressure was high. So we have decompressed with the flatus tube, and we have drained the peritoneal fluid. But increasingly, when I was trained in Australia, we used to see a lot of this open abdomen. So because I was at Twilight Led, where we had at any point of time in ICU a pancreatitis or abdominal with an open abdomen, especially in pancreatitis setting. But now, currently, seldom I'm seeing in pancreatitis, or which is commonly seen. That's why I'm citing this. If it is a frank surgical patient due to intestinal obstruction, abdomen being open with a vac dressing is seen often. But in a medical conditions, leaving the abdomen open, I think there has been little de-emphasis, and we are resorting more to percutaneous decompression with percutaneous drainage of the fluid. And in fact, there is one study in chest which is shown that percutaneous drainage of fluid, if it is successful in reducing IAP by 9 millimeter mercury in first 4 hours, that shows there is a success of decompression. It open abdomen really doesn't help. So that's the sort of thought. So open abdomen, at least in my sort of a hospital setting, I'm seeing little de-emphasis on opening. But of course, there are a lot of studies to suggest that if we do not address persistent intra-abdominal hypertension, where there is a persistent IAP more than 20 to 25, it has a direct correlation with morbidity and mortality. And that's the situation where early decompression with a surgical incision, which is anterior fasciotomy with 3 incision, is sort of increasingly sort of suggested or recommended. And sooner it is done, better it is, because the more longer period of time the IAP remains high, the mortality is put at more than 80%. If it remains at more than 20 or 25 for at least 40 to 72 hours, it has a direct correlation. So this is the sort of science that is there. But how much we are following and pushing our surgeons to do decompression, I think I would remain still skeptical. We are not possibly doing much. So maybe I would love to hear what is happening in the cancer with Parveen, Kaur or Supradip, whether they are doing a lot of decompression, surgical decompression. Obviously, medical decompression is easy. We put a nasogastric tube, we put a flatus tube, we remove whatever fluids with percutaneous decompression. These are all simple things. But coming to more invasive skin incisions, multiple skin incisions from top to bottom, whether are we doing it aggressively? I think there has been little de-emphasis in my setting. So I would love to hear from you, because the complications with keeping the abdomen open also is multifold, and that is the next question which Astha would ask. So it's all the intuitive sort of an answers that every listener would know. This is more of infections, more of fluid loss, and poor wound healing, nutritional issue, and so on and so forth. But I would love to hear from my other colleagues whether surgical decompression is something that's happening in that practice.
We hardly do it, Pradip. But yes, we have done it in earlier with pancreatitis. Our surgeons used to be quite aggressive. So they used to use that Bogota bag with a Foley's this catheter bag is inverted and put it in there. One of our surgeon who is now in Bangalore, in Manipal group, we used to use a zipper in that bag. But nowadays we hardly see, and it's extremely difficult to manage. These patients are in a pathetic state, smelly, fluids leaking from everywhere. It's difficult to take care of their fluid balance, difficult to maintain the infection things, and many of them, they do not survive. So fortunately or unfortunately, we don't see it anymore. Hardly we see it. Maybe Parveen can have more.
We are also not doing surgical decompression for this, but where the surgeon is suspecting that there are chances of getting this IAP thing, they tend to put drains wherever they feel it is required. But surgical decompression per se, I haven't seen. Not doing much of it.
Thank you. We have some questions in the chat box, but I think many of that already answered. If you can take 1 or 2 questions.
I think one question that was asked is, what is the overall prognosis and mortality rate of intra-abdominal hypertension in critically ill patients?
It also depends upon what is the primary conditions. Like for in patient with burn, it is quite high. The patient with burn having intra-abdominal, the mortality can be as high as 80%. There's some study comparing the prognosis of prognosis in patient in medical and surgical patient. I think medical patient, they have worse prognosis than surgical patient. Again, the patient with pancreatitis having high intra-abdominal pressure, the mortality may be as high as 50 to 60%. Like it depends upon the patient's primary conditions. Any comment from Dr. Other panelists?
Factors which need to be considered is what is the level of pressure? How long the pressure is there in that level? what is the level of organ dysfunction, and how long this organ dysfunction is persisting, whether it is just an organ dysfunction. It also depends on, as you rightly pointed out, what is the underlying pathology, what has caused, and whether is it treatable or is it easily treatable. For example, we had a patient of dengue who bled in the abdominal wall. Dengue patient who bled in the abdominal wall. We published it in British BMJ, that BMJ case report, paid wala, and that when the surgeon decompressed, patient immediately improved from abdominal compartment syndrome with complete shutdown of the kidney. The patient improved immediately. So it again depends on how easily you can treat the underlying disease, underlying condition which is causing the abdominal hypertension. So there are multiple factors. I don't think any single answer can provide the thing.
Just to we talked about abdominal perfusion pressure, Supradip mentioned, and we were talking about them. There's a reference that if we are not able to maintain abdominal perfusion pressure, which is mean arterial pressure minus IAP, more than 50, so that seems to have a good correlation with increasing mortality. But so there is reference for that. So 50 for all the audience here, they can keep that in mind. And just I want to throw one question, like see in chronic liver disease, Supradip and Parveen can ponder on this, because how often do we do intra-abdominal pressure? Because they have massive vasculititis, and when they go to acute kidney injury, very seldom we call it as hepatorenal and leave it. But very often abdominal pressures will be high because we have looked into it, and very often we see their intra-abdominal pressure. So drainage sometimes as a therapeutic modality may have to be considered, and this may not be someone with massive visible ascites. It may be we would just take it as a norm in CLD. So this is also something one should ponder on, I think.
Today only we have a patient who's she's a lady with metastatic CAGB, along with she has CLD. So she had ascites. She was not symptomatic, not complaining of any abdominal distension. There was some fluid. We were draining around 500 ml if required. But today somehow she has to undergo for a procedure for PTBD. So once they drained the fluid for this thing procedure, and immediately after few hours urine just started pouring in. So it was, if we were looking at, I did not suspect that can be the reason, but urine output was borderline. But immediately as they drained fluid, after a few hours, it has shown significant improvement in urine output. Or sometimes, yes, drainage is very, very helpful.
I think the effect of acute rise of I and the chronic, I think, a bit different. Even patient with obese, when they have increased abdominal pressure, and it can cause, sometimes this patient can have pseudo tumor cerebri, they have high ICP, and with the reduction of weight, this condition recovers. So I think these are a bit.
It has to be individualized and patient to patient variable. It cannot be a generalized thing that it has to be done for this patient. I think that is why every time we keep on emphasizing that detailed history, detailed examination in proper context is helpful. It cannot be just a simple thing for everyone.
Okay. Any other comment? I think we are now at the end of our session, and for me, it's really a great learning experience. And thank you all the panelists and the audience for joining, and it's a great source of encouragement for us. Any other comment?
Thank you, Saurabh. Thank you, Parveen. Thank you, Supradip. It was great having the father of intra-abdominal hypertension, Professor Manu Malbrain, with us. So we learned a lot of lessons, but as I said, we should possibly do more observational studies in our own setting. And constipation is another one which I would strongly feel that we should all look into it in ICU.
Yes, very right. Because most of the times constipation is something which people will normally not even ask. It is just like that. So I think it is very, very important and it should be taken care of.
Yeah, and it's an organ dysfunction, I believe, many times.
Dr. Supradip,
we have to agree that our forefathers, we Indians, our forefathers has learned it many, many years ago.
Yeah.
So thousands of years back, our forefathers said, "Pet saaf honi chahiye."
Pet saaf hona chahiye. And especially our elderly parents, they'll also
and this is true. This is so true. Pradeep is rightly pointing out. It is so true.
And
Mm.
the
we
movie
need more
Me Too-
data. Probably we can generate a huge amount of data from things. I think Saurabh, you have done a fantastic job. Dil se, बहुत बढ़िया.
Very
Thank
nice.
Very
you.
nice. Thank you
Thank
so much.
you. Thank you, Saurabh, for
I think
having
we
us.
should have more similar
Discussions,
discussions.
Yeah.
Beautiful.
Thank
मजा
you,
आ गया.
everyone. Thank you
प्रदीप
so
के
much.
साथ बहुत मजा आता है, ऐसे भी परवीन के साथ और सौरभ के साथ.
Oh,
मनु तो
same
है
thing
ही.
applies to all the esteemed panelists here,
Yes.
Supradip. It's always nice.
Thank you,
Thank you.
Astha.
Thank you, thank you,
you.
thank you
Astha,
all.
Thank you.
Astha,
It
thank you
was
so much.
Thank you,
no, it
Astha.
was a
And
great
cheers.
learning experience for me. Thank
Yeah,
you.
for us also.
Thank you, thank you all the delegates as
Thank
well.
you.
Thank you.
Thank you.
Thank you.
Thank you.